sing to loads of people and found I mean,
there is lots of people to find.
You get in some funny situations.
Yeah.
Yep. Good evening. Good evening. Welcome to the webinar of EUCOMS, the European Community Mental Health Services Network, together with the European Forum on Primary Care. And we opened this webinar with live music, and this was the band Co-operative Harmony performing live from Haywood as part of Greater Manchester in England. EUCOMS, we do these webinars at least 4 times per year. And today the topic is on primary care, and that's why we joined forces with the European Forum on Primary Care. So my name is René Keet. For the people who do not know me, I'm a psychiatrist in the Netherlands and chair of the EUCOMS network. And I'd like to introduce first my co-chair, Dineke.
Yeah, my name is Dineke Smit. I'm a researcher on complexity of mental health of good care. I would like to thank you all for joining today, and thank you for being interested in the role of primary care and community care for attending to mental health. René, will you introduce the first speaker?
Yes, the first speaker is, you already saw him. He was also performing in the Co-operative Harmony, he was the guitar player there, but he made a rapid shift from performing in the studio to now being the first speaker. As always, we open our EUCOMS webinars with the story of a person with lived experience. And today that is James Crawshaw. James, can I give you the floor, please?
Of course, thank you. First of all, I'd just like to thank everybody for this opportunity and this chance to speak from a person with mental health difficulties and mental health issues, and being able to give us this chance to speak out. I have spoken to a few friends as well to gather some information just on how their health has taken tolls with primary care. And one of the first things that we find is that there's inadequate access for people with mental health that are trying to seek help. There's not enough GPs in the actual surgeries. There might be, I think there's 3 to 5 surgeries in this town alone, but out of them surgeries, to try and get somebody to help you with your mental health is very, very difficult, because you're on a 10 minutes time slot. So if you stutter like I do with PTSD and all these initials that I've got after my name, and not one of them give me a diploma, but I've got lots and lots of them. But when you go in there, you need to have time to talk to the doctor. You need compassion. You need empathy. You need your GP to understand what you're saying. And a lot of the time, it seems like they're just staring back at you, thinking, "What drugs can I give this person to get them out of the room within 10 minutes?" And that leaves you. As a person with mental health difficulties, the people that I've spoken to as well, all know, and they all understand this feeling of walking out after not being listened to, just being got rid of. So it seems like it's something that sticks with all the people that I spoke to. It's about 15, 20 people, but I mean, over the 20 odd years that I've had mental health issues myself, from PTSD, personality disorders, bipolar, ADD, ITSD, loads and loads of things. I don't actually know which ones I do have, which ones were just given to me to get me out of the doctor's office or what was what. But that was one of the things that I found, is definitely not enough people that are specialising in mental health in GPs' offices. It feels like you just walk in there and then you're shoved onto a psychiatrist, or you're shoved on drugs, or you're shoved onto, onto secondary care. There's nobody there that actually wants to help. They just want you in and out as quick as possible, as though they're sort of working on commission in a way, So the lack of empathy and understanding from the GP's point of view is very important for people that are walking in there with mental health issues. If you've got, like, some of my trauma is due to my ex-partner and my children, and she used to beat me up, and that still went on for 17 years. So it was needing to talk to a doctor about that took quite a few years anyway. So I was already in quite a state by the time I'd actually got to the doctor to speak to him about that. And then to be rushed to talk about it when you know, I'm already starting to stutter now. So I apologize for starting to stutter, but it's a very, very big thing for a lot of people with mental health, that they find that there's no empathy when they walk into the doctor's surgery, when they're talking to the doctor. And then there's actually talking to the doctor as well. When we ring up a doctor's surgery and we're trying to get an appointment with a GP, a lot of the time we could be talking 2 weeks of waiting. So if you've just gone through your trauma or you're feeling very anxious, you can't wait 2 weeks to see the GP. Sometimes you need the GP straight away. And I know that's not always possible at the moment, you know, but there's got to be some kind of buffer where people can go, which is what I find here at Recovery Republic. Just getting a bit ahead of myself at the minute, but I know that there's a high patient demand in the doctor's surgeries, which is why there's not enough mental health GPs. So, you know, a lot of people end up not wanting to go. They'll make the appointment for 2 weeks and then either forget about it, or they've gone into a worse depression state, or their anxiety has just got to the point where they just can't move out of the house, they can't move out of the chair. I got to a point where I wasn't washing the pots, I wasn't getting out of bed, I wasn't even changing my clothes, I wasn't doing nothing. And you know, it was due to a lot of things. It wasn't just the fact that you'd be waiting a long time for the doctor's appointment. It was also, once you'd had the appointment, there was a lack of explanation to your illness. So I found a lot of people at the minute are going on the internet, and they might find out they've got bipolar. They'll go on the internet, they'll type it up, and they'll find out all these other symptoms. And then for some reason, psychosomatically, they take on every symptom that bipolar has and things that are linked to it. And I'm seeing that a lot. And, you know, I did actually do that myself, because it wasn't explained to me what was wrong with me. When I was told that I had anxiety, I was told I had anxiety and panic attacks, which really didn't help me. And depression, that it didn't help me either. You know, it was 20 odd years ago when I got diagnosed with this. I was given some tablets which helped in the short term, but in the long term it just made things a lot worse, because there was still nothing happening. There was still no explanation. I was sort of in a limbo of where am I? When do I get better? Whereabouts, how ill am I? Do I need to go to an hospital? Do I need to be looked after all the time? And it came to a point where I couldn't actually live on my own. I had to have a friend living with me, or I had to be with a partner all the time, or I'd be constantly ringing my mother up asking her to come and see me all the time, which for me was quite distressing, having to have somebody there all the time and having to ask somebody there all the time. Which leads me on to Recovery Republic, because with the lack of local places that there is to go, here at Recovery Republic, I found that, because I've not spoken to my GP since before lockdown, not about my mental health anyway, and I found that I've not needed to, because when I come here, there's people with similar issues. There's people that have got no expectations. There's volunteers that will say to you, it's okay if you're late for your appointment at 11 o'clock, it's fine, come in at 10 past, come in when you're ready. We'll sort something out. We can sort a different time out for you when it suits you, it's okay. And it took me 3 years before I actually stepped foot through the door. I was talking to the staff on reception for over 3 years, to Keet and Anne, for 3 years. Yeah, it took me because of my anxiety. And also the stigma as well of walking into a place that's called Recovery Republic. And as I said, with all these initials that I didn't understand and all these illnesses, with no doctor explaining to me or no psychotherapist saying, look, James, this is what's wrong with you. This is where it starts. This is how we're going to go about it. Writing a diary all the time is no good. For me personally, I write music. That's how I write my feelings down. And that has always helped me. Music has always been my best GP, best psychotherapist. My guitar will always treat me the same. No matter what I do to it, it always treats me the same way. Brilliant. So here, I found that my primary care needs have actually been met here more than they ever have with the GP. And here, the NHS is so struggling at the minute with people going to hospitals because the doctor's surgeries are saying, we can't get you in for 2 weeks. But somebody will say, well, I need help right now, this minute. So they're then told to ring 111 or ring 999 if you're having suicidal thoughts or something. So that then takes on the whole thing of the NHS getting stuck with people that aren't actually as ill as they think they are. So that's why I think that Recovery Republic makes a really good buffer in that sense, where if you're waiting to see a GP, you could come to Recovery Republic while you're waiting for your appointment. And while you're here, you will find things that will help your anxiety. There's people to talk to, there's people that make you a cup of tea, there's little rooms you can go, there's projects you can do. And you end up becoming a volunteer and you find your validity again as a human being. You kind of realize that, I am a real, genuine person, and I do have more reason to be here other than just sitting in my house being ill. And there's one last thing on the GP surgeries that I didn't mention is that people that do have anxiety issues, or people that have panic attacks, or maybe people that are agoraphobic, or that struggle to be indoors places, the GPs don't have any facilities to deal with that. Luckily for me, when Dr. Michael's surgery was open, he realised the seriousness of my illness, and he used to ring me up when there wasn't as many people in the waiting room, and then I'd make my way down to the surgery. So that was a great help in helping me get a little bit further, so that I could actually see my GP. I was quite lucky in that sense. But the main thing that bugs me is this stigma that is all around the mental health, and I think that is what is stopping people from actually going out and getting help. There's a lot of friends that I have that have got a lot of illnesses and that need to go and seek help from a GP, but they're not actually trying to find it. So I think, to wrap up what I'm saying, I really think that places like Recovery Republic are very important to the mental health community. And I especially think there needs to be a lot more mental health GPs that specialise in, and more facilities to help people with mental health issues in a GP surgery, or, like I said, a Recovery Republic that's local to the surgeries. So I hope that helps to sum up. Thank you. Thank you very much for listening.
Thank you so much, James, for sharing your important story with us. Very important. Many things you've told, indeed. First, that you had all these different diagnoses, or being classified in many ways, but it doesn't tell much about you, and how important music is for you, and how important a place like a Recovery Republic from Haywood, where you are performing, and how that in fact helps you to sort of regain your identity and the importance of music.
Yeah.
So very important message, James.
Yes.
Thank you. You have many roles in this webinar. As you opened with music,
you.
we'll see you later again with more music, and you will be present in the Q&A section.
Yeah, I have a lot more to say though.
Yeah, I'm sure, James. Yeah, we already met, and you have a lot to say. You have an important story to tell. So thank you
very much, everybody.
Thank you, James.
Sharing that with us.
Thank you.
And
minutes.
before I give over to Dineke, welcome to the audience. We have over 50 participants now. My question to all of you who are participating is, please introduce yourself in the chat. Tell us your name and at least the country where you're from, and if possible also the service or the city where you are from, so that we know that we get to know our audience. And please ask your questions. There's also a Q&A button in the bottom part of the screen. So please put your questions. Don't wait till the Q&A section is there. Already start giving your feedback and your questions in the Q&A, because in the second part we will have time for your question and answers. So please use the chat for your introduction in the Q&A for your questions. And I hand over to Dineke Smit.
Thank you, René. It gives me great pleasure to introduce to you Lisa Hill, the next speaker. Lisa is from the Recovery Republic, where James just was talking about, and how wonderful it is. Lisa is a registered nurse with an impressive background in education, finishing now her PhD in education at the Staffordshire University. Lisa is also a member of the working group Mental Health of the EFPC. And I just in front asked her, why are you so interested in primary care mental health? And then she said, I'm just crazy about it. And she's for many years, the most thing she loves is being there, as James Oak said, being there for people in need, and share the vulnerability about mental health problems. Lisa, I'm very interested in your research, and please tell us more about it.
Oh, thank you. So my research started just before lockdown, and I've made this presentation as short and as unacademic, you'll be pleased to know, as possible. So here we go. So my inspirations, my first inspiration was when teaching and working with GPs, and one GP talked about the disconnect that he struggled to implement. Sorry, just move this. He struggled to implement the policy and guidelines on mental health. So I observed a disconnect between policy and between practice. Further disconnects were raised by a pilot group that I had together of people with lived experience developing this research that I'm going to share with you. And they told me that no one had ever asked them before. And then I had validation, because I also found in my findings that there was a disconnect also between the community and primary care. And one of the comments that I had from one of my participants was, I've had a lot of brush-offs, a lot of it. So I'm kind of glad you're asking my opinion. And I was glad I was asking the opinion too. The first thing I did was to try and understand what the GP had said. Why was there this disconnect between policy and practice? So I looked at the history of, in the UK, since GP fund holding, which is 1993, when they started shutting down, the policy of closing the asylums came in to get the historical context. And as somebody who'd worked in the asylums, it was very important to me to understand what had happened over the years. And what I found was top-down centralised policy, a disconnect between policy and practice, a lack of definition of what primary care mental health was, and a lack of guidance of what's going to happen post-pandemic. I also looked at GP education and found there was a lack of undergraduate training on mental health in primary care. And in fact, placements were often hospital-based, or they were within psychiatry rather than the community itself. So people weren't understanding the mental health in primary care. There was also a move towards transactional care, where you look at the cost per contact, rather than relational care, which looks at continuity. So they were looking at quantity rather than the quality of care. And this move has gone on. Consultation wasn't with the communities. When I looked in the documents, I looked at who they consulted with, and they were with large charities or large quangos, large organisations. And in fact, this was picked up by the United Nations looking at the UK, finding that individuals and communities weren't being consulted with. It was rather with large bodies. I've put down the Diagnostic Statistical Manual of Psychiatry, and this may be contentious, but that's because the community stubbornly refuses to fit into the boxes of the DSM, which makes primary care complicated because people won't fit into the boxes. And are they actually suitable for primary care mental health? And the other thing I put down was technology. I was looking to see where participation had worked, and where it's worked is actually in Australia, where they've engaged local communities to develop apps, which are hugely successful with 80 to 95% uptake because they've been done with the community. Sadly, looking at all the data and trawling the data that came through COVID and through that period of pandemic, and thank you to Marc and the report that he produced as well in 2020, started finding information that showed there was institutional racism, long-term health issues, overcrowded or inadequate housing, or even access to housing. The impact on COVID on public-facing workers, which I'll talk about a bit more in a moment, issues around employment and unemployment, poor social capital, a lack of investment in our communities, and a lack of investment in justice, all linking to reduced life expectancy alongside not being able to access or cancellations in routine care. And this all led to the inverse care law, first identified in 1970 by a GP called Tudor Hart in South Wales. And the inverse care law is that those with the most need get the worst care. The literature review gave me some information. It gave me 3 supportive theoretical assumptions. 1, that primary care mental health is complicated. 2, participation is essential. And 3, my methodology, the way I designed my research, needed to be inductive. It needed to grow from the bottom in a rapidly changing environment influenced by both the pandemic and now post-pandemic and politics. And I don't need to tell you about UK politics. So 2 questions. Was there the potential to produce a learning theory, was my question from an educational perspective for primary care that considered community perspectives. And actually the government policy was there throughout all of the policy of community participation. Would it enable enactment of the community to be involved in primary care mental health education and training? So the method, the way I did this was I had a pilot group of technical experts, absolute brilliant people who had lived experience, who helped develop my methods and also my research proposal. This led to a focus group, which was done pre-pandemic, and I used 2 techniques. One was appreciative inquiry, where you look at positives, and the second was using Disney modeling, which was an amazing technique. In groups of 3, and you have a dreamer who sees the vision, a realist who says, well, actually, is that doable? And a critic who then critiques it. And you go round and you produce themes, and it produced my initial themes for this research. Then we had COVID hit, and I was unable to do any more face-to-face, so I did telephone interviews with 14 people. Some of them worked in health and social care, some of them had mental health problems, some of them were employed, some unemployed, all different backgrounds, and recruited them from one area. So my findings. So the first thing I asked, the first question, I'm not going to go through all of my findings, just some main points. So the first question was, what is primary care mental health? I thought I'd ask a barn door obvious questions. What I found was that the term primary care mental health was understood by some of the professionals, but not the community participants. They didn't understand. There was a lack of clarity regarding the function of primary care. The voluntary sector, those who worked in the voluntary sector, they perceived their own services as the first access point for mental health, which is what James has so brilliantly summarised, how people get their primary care needs in the voluntary sector. Whereas clinicians, they had a different view, and they saw the health service as the first entry point for mental health. What was clear, though, was those with lived experiences were confused about the services, who was who, which doctor was which, and how it all worked together. There was a mass confusion. And I'm just going to pick up on the last statement here on these four. I want to pick fifth statement, which is from somebody who was an NHS nurse manager, and her comment was, I don't think that most lay people locally have a concept of primary care. They know about the individual services, but they don't know about it all being more closely tied together now. I don't blame them for that. What was, so what was agreed is that everything I developed was member checked, which means the person I'd interviewed also saw it, a proportion of them would see it and make comment. And they agreed on this statement that primary care mental health is viewed the same as primary care. It's the first port of call for mental health where a local doctor was based, offering advice and support. It didn't matter who that doctor was, but there was a doctor there offering advice and support for mental health. The themes that I produced, that were produced, they were over 1,000 pages of transcript, and the themes that were produced included the impact of health inequalities, and that also included a lack of cultural competency, and the impact that COVID had had on frontline workers and those with lived experiences who are struggling. Stigma I'll come to in a moment. Relational care, and this need to stop telling traumatic stories, as James said, and stop reliving the traumatic stories and repeating them. That what was needed was listening, understanding, and that built trust. And only when you had listening and understanding and trust, then empathy was present. And that was something that I'd learned. And there was a lot on relational care. The transactional approach was described as either hindering or even preventing help. And the model of care that people discussed was having overuse of services like 999, which is our emergency service, and access to casualty, A&E, as a default from primary care, misuse of services, going to the wrong ones repeatedly, or what was really worrying was underuse of services and people not accessing their GP when they had physical health problems and needed help and support. And what was wanted was a one-stop service. GP education was the main focus, and we looked at soft skills such as communication, and also harder skills like how to manage psychotic crisis in primary care, and the ability to do that and to use medication and monitor medication and prescribe, and side effects. And then the workforce, and the workforce in primary care, there was a lot about the workforce and about using pharmacists during the pandemic, but also about how they needed skills, of customer service skills and mental health awareness, so they knew and could help and support people when they presented, because people with lived experience did not feel welcome always at their GP surgery of the interviews. And finally, the intrapsychic. And I use the word intrapsychic, and I don't apologise for using a Freudian term. So it's an intrapsychic is looking at, it was developed by Freud, it was further developed by Carl Jung, and it's the participants wanted more than a biological response. And they spoke about how their beliefs impacted on their well-being, and they looked at their adaptive strategies about how they coped, and how religion, spirituality, faith and beliefs, whatever they may be, how they impacted on their well-being, either positively or negatively. And that also included why they went to their GP and looking at the power of the GP and the language they used, almost like confessional language that they used. Very complicated side, please don't worry about it, but this is where I mapped all the themes and pulled out the data so that there were sub-themes underneath that I could start examining. And here's an example of one of those sub-themes, and it's self-care, it's stigma is the main theme. And then the four sub-themes are self-care and stigma for participants with a professional background. And this was quite a shock that those people who had professional backgrounds that I interviewed didn't present with mental health problems to their GP. And they didn't tell people at work or their colleagues they had mental health problems due to self-stigmatization and fear of their professional networks and of what people may think. Also looked at stigma and diagnosis. This is somebody with a lived experience. And she said lost jobs were some really, really bad experiences until recently. Moving forward, it's got better. And this is just because I have cyclothymia. It's interesting. If I was able to put on a job application, I have this. Or if I was able to say to my boss, I don't work because of this condition, but I never tell them anything because I don't know what they're going to think. And then when I do act out, they sack me because I didn't tell them I was ill or be able to tell the job centre. And I'm confused. I've got all these different diagnoses. I've had to send in my medical records. So because it's wishy-washy, it's, well, do you have it or not? Because suppose drinking was the symptom. Another lovely person with a long-term mental health diagnosis of bipolar actually said, I'm not embarrassed about mental health. If I don't tell people, it's because I have my own reasons. This person doesn't need to know. And finally, I looked at stigma and inequalities. And one of the things that was found was that everybody I interviewed spoke about not feeling, same as James did, how the impact of stigma had impacted on them, apart from one, a very senior NHS manager and their relationship with the GP. And he felt that he was seen as a partner. In fact, they talk about the fact the patient is a partner in the treatment. Unfortunately, nobody else I interviewed felt that. So I was looking at learning theory. So I mapped learning theory and their relation and against the themes and the sub-themes. Very complicated slide. So here's picking one example, stigma. And the three learning theories that came up for stigma were values-based education, the need to reflect the community's values and what they think. How transformative learning theory can use co-production and participation to gather those values, and how reflective learning theory can reflect on what's been learned. And one of the lovely examples I have with the people I interviewed was they felt they could help primary care with reflection by looking at cases and looking at how things had changed. So is there the potential to produce a learning theory? And the answer is yes. And the theory that I've adopted is something called collaborative learning theory. And collaborative learning theory is one that shows how the disconnect between policy and practice, and also remember community and primary care, can be managed using a collaborative approach, and that will support the implementation of something called a values-based learning framework. Question 2 was whether the government policy of community participation in mental health enables policy enactment concerning training and education in primary care mental health. And the answer is not yet. There is no explicit model to engage the community and hear their voices in primary care mental health education. Some work in Turkey during lockdown, fantastic work with participation, showed that you need to contextualize mental health. And communities are not passive, they're proactive, they doctor shop. Every person I interviewed with mental health problems, including professionals, had doctor shopped. And when I say doctor shop, it's not meant traditionally, as we say, people with addiction go to doctor for medication. These are actually members of the community who went to different GPs because they weren't happy with the relational care that they were getting. And they were very explicit that it was the relational care that made them choose surgeries, some of them traveling great distances to get to them.
Lisa, for the time's sake, can you wrap it up and get to your conclusion?
Yes, absolutely.
So I know you've got more slides and a lot of more information here, but you have still just 1 minute.
Oh, thank you. So anyway, thank you very much. So the conclusion is we have 6 C's, 6 competencies that people may be aware of. These are moral. And the NHS has adopted the 6 care, compassion, commitment, competence, courage, and communication. What I'm suggesting is that to adopt Tudor Hart's model for primary care, that we include collaboration, continuity, and community. There's a community of practice model. I'm very happy to send these slides to anybody, which looks at a 3-step approach to participation and looking at what you may get from it. So in summary, We have the aesthetic, the surgery is important, it needs to be welcoming. Relational care that's built on compassion, continuity and trust, as James has said, with collaborative learning theory, values-based communities models, community and practice models, values-based education that includes language, a discourse that includes the community, that isn't jargonized and is about discovery, connection, listening and caring. Thank you.
Thank you very much, Elisa,
You're welcome.
for your presentation and for addressing that we have to connect on all levels.
Lovely.
René, can I give you the floor again?
Yes, absolutely. Before I introduce the next two speakers, really welcome to all the people who are present. We have 56 people now present, and from many different parts of the world, across Europe, from England to Turkey, but also from the USA, from Africa, from Asia, India, and even Japan, where it's in the middle of the night. So that's really a hero of this webinar, Takashi is there. So we have many people, and many of you introduce yourself in the chat. Please keep doing it if you haven't done it yet, but also use the Q&A, because the second part will be driven by you, by your questions. And so please give your feedback, give your questions, put them in the Q&A, so that Dineke and I in the second part can help that your questions are being answered. So please do that. And but now we go. We just were in England. Now we cross the North Sea and go to Belgium, and we have two speakers there, and they're both practicing GPs in Belgium and also involved in the academy and the University of Leuven. And the first one of them is Marc Nuland. So please, can I give you the floor, Marc?
Yes, thank you. Maybe I can wait to still I see. Yeah, okay. Thanks. So wait a minute. Can you give yeah, okay, thanks. Yep, there is a delay before. I can't go to the next slide. So sorry. Okay, well, you do use this way. So that's us, the two of us that are going to present this presentation. Thank you, in fact, for being welcome to join this webinar. Yes, so, I will give a short overview of how primary care, mental health care is organized in Belgium, and Geert will focus more on the caring neighborhood he's involved in. So from a public health perspective, we are lucky in Belgium that we have this national-wide survey about health issues, including the mental health issues. And it's done every 5 years. These are the results of the 2018 survey. And what's the conclusion for us? That the prevalence of mental health problems is rather high, and that there is a need for coping with the problems. When we look at how mental problems are treated, and this slide we thank to René Brufas from the same University of Psychiatrist in Leuven, and he found out that it appears that 60% of patients have unmet needs, and certainly it's the long delay that plays an important role in it. Then that means 40% have met needs. But when we see how people are treated, that it's less than 1 out of 3 that have the adequate treatment, and there is rather a high portion of people that get some overmet needs, in the way that they get over-specialized care, go too fast to the psychiatrist and things like that, or stay too long in care. That's also a real problem. The structure of our care is probably like in many countries, based on an echelon-wise organization: the primary care, secondary care, and tertiary care. Of course, we would like to focus on the primary care part. But what is certainly a fact is that certainly in the past, the self-care and informal community care has been given little attention and not that much support that it should need. And when we look at the WHO pyramid, that means that there is a big opportunity to to invest more in focusing on this level of care. So what about primary care? I think the general practitioners have a central role for several reasons. First, there is the low threshold. Most of the people know their GP. A second point is that as we have a co-payment system, that means that people don't have to pay the whole price for their consultations. The threshold is really low. And third reason why is that a lot of mental health problems are first signaled with somatic symptoms, and there the general practitioner is well known to be the first point of care for their problems. The first line psychologist is a new kind of first primary care provider, also giving a low threshold. There is also this co-payment regulation, but it only started recently, so that means that it's not yet that well known among all people. That's one thing. And another thing is that for the first-line psychologists themselves, it's a little bit uncertain how the government is going to do the payments for the next years. There is some doubt about, we hope of course that they will enlarge the number of first-line psychologists, and that this will be a really helpful way in handling the mental health problems. Then you have the psychotherapists. There is a free market, but there is a higher threshold because there is no co-payment, and certainly for the unprivileged, that means that there is a very important financial problem. Regarding social workers working in primary care, the problem is sometimes that there are a lot of doors you can open, and it's not always clear to the public which one they need to contact for their problems. And then you, of course, in a new evolution is this kind of mental health coaches, but there is missing some legislation about, yes, how good they are, about the evidence-based they're working with, and so on. About the secondary care and tertiary care, I won't go in too much detail. I think I've put here in the slide the most important things, that you see that there is also this problem of overcrowding, long waiting lists, not always that easy to go to. That's one thing. And if we compare Belgium with other countries in Europe, example given, in fact, we have too many hospital beds, both in secondary and tertiary care. And that's one of the things that is now changing, but of course it takes time. If we look at the current challenges, I think one of the things is that many patients, but also GPs and other primary care health providers are struggling with this feeling of being lost in the labyrinth, because there are so many instances that you don't always know how to get there or where to find them. So there is certainly a need for better integration. That's one thing. And then for all the new initiatives, there is also this implementation gap. That means that there are possibilities, there are good pathways, but before they get implemented in the care by all care providers, it takes a long time. Another point I would like to make some emphasis about is the inequity, of course, regarding the access of care, and that's certainly a problem that the people most needing help and support are often those people that have to wait too long. Yes, we heard a little bit this story of James too, that there is this problem of waiting lists when you have an acute problem, example given. That's the same problem we are confronted with. And then about training of GPs, I would not like to say that GPs are not trained. Yes, they are trained, and some are trained very good and are very competent in addressing mental health problems. But there's certainly also a portion of GPs that don't have the skills and that maybe don't have enough interest in handling this kind of problems in their practice. And that means that those GPs, the patients of those GPs, they stay a little bit yes, in the cold, by way of saying. And a lot of those GPs also are tending to solve a lot of problems with medication, where mostly medication is not the first choice. And yeah, that's really one of the other things. And that's the final thing I would like to emphasize about the current challenges. That's the medicalization of the mental health and the drug overuse. And that in Belgium, we have the unlucky price of being one of the countries where benzodiazepines are used a lot or prescribed a lot. Antidepressives are used a lot. So that's certainly a thing we need to work upon. Then what
Marc,
are some
Marc, can I
changes?
Marc,
Yes.
can I interrupt? Because we're halfway the time.
Okay.
So can you
Okay,
represent
but
that Geert also has time for his talk?
Okay, yes, but this is my final slide.
Right.
So there are just current promise-filled changes. That's what I would like to say. And I give the floor to Geert now.
Okay, thank you, Marc. I'll see if I'm in control now. And I will have to wait a bit. I'm very delighted to welcome you all to Leuven, Belgium. I think you should all visit Leuven if you would have the opportunity. It's a very nice city, but I'm not here for a tourist talk. Leuven is one of the primary care zones. We have 60 primary care zones, and Leuven has a bit more than 100,000 inhabitants. And I'm talking to you about community care, mental health care in the community. And this is all embedded in a much larger project, the Chronic Care Project, Care in Leuven, which is one of the pilot projects of our government to start reorganizing and rethinking chronic care in Belgium. And so we in Leuven, from the start, we integrated mental health care partners as well as welfare partners and the local authorities in the steering committee and in the work groups, because we think that if we're talking about chronic care, integration of care, we should stop putting ourselves in these separate silos and really work together from the start. And once we've given this opportunity, we were starting like this from the start. There are 6 keystone pillars in our project, going from population management to caring neighborhoods, teams and collaboration between teams, payment mechanisms, development of expertise and sharing knowledge, and communication, data sharing, and digital support. I'm going to talk to you about the caring neighborhoods as one of the pillars in our project. So me, myself, I'm a GP in Wilsele-Dorp, which is a caring community. We try to build a caring, resilient community. It's a very small part of Leuven. We only have 5,200 people living here. But despite the fact that we are a small neighborhood, we have lots of partners involved in this project. And that's one of the big, well, I think big good things about what we're doing. So besides the primary care partners, we also have the mental health care and the welfare partners like the local community center and a local service center. But we also involved from the start people living in our neighborhoods, and we have a local civilian group. We invited the local leisure associations and the primary school to join and to see what are the strengths and what could be done in our community. So we started by doing an analysis of our neighborhoods. So this is actually the neighborhood you're looking at now. And as you can see, there are different types of housing. So from solitary houses to social blocks, and there's a wide diversity of a socioeconomic status in our small neighborhood, which is a good thing. And so we can mix together. And we did this analysis once using numbers we got from a survey of the city of Leuven. So they do every several years surveys, but we also did discussion groups with mixed discussion groups where we invited well, citizens living here and the formal workers, and we discussed the strengths and the needs and the weaknesses of and how to connect. That was actually the main question, is how to connect informal and formal care on our neighborhood, in our neighborhood. And these are some small numbers just to show you that we have a slightly older population in our neighborhood, and that well, almost 7% of the people living here are not able to pay for their health costs. 77 feel very happy, but on the other side, 26% feel stressed, and almost 14% experience moderate to severe mental problems. So this is the people living here in our neighborhood. And then we could look at the people working here. And as you can see, I already said, and I emphasized it, that this is a very small region. We only have 5,000 people living here, but we have lots of people working in primary care. This is primary care. So we have three GP practices. We have 5 physio practices. We have 2 pharmacists, dentists, as you can read. So this is actually, and we didn't even know before we started with this project who was working in this small region. So if you think about Leuven, which is a city of 100,000, has 20 of these kinds of neighborhoods where lots of people are working, not together, not in an integrated way, but next to each other, and all doing things for maybe the same patients over and over again. So it's really time that we rethink about how we should try to organize our work. And besides the fact that we are so many people, we also speak other languages. I think we all agree that if we thought together that it seems that we have other goals, that we have other ways of discussing things. And so I was very happy to discover positive health as a concept, a new concept on health. And so for me, it could be a catalysator for integration, because it could fill in the role of being an integrating language. Health is seen as the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. And for you people working in mental health care, I think it really resembles the definition of recovery in mental health. So this really helps to talk the same language. So this is the spider web that is used in positive health, and it's actually a practical tool in daily practice to start the conversation with the patient and with the person. And it's a way of looking at what is important for the patients, sitting on the other side of the desk. It's looking at what's important for them. It's looking at what's their strength. It's what is for them important. And mental well-being is one of the dimensions of health, like bodily functions and like participation in the community. And they are all equal. They're all as important as one as the other. And for me, this was a mind changer. We should stop taking health as a main goal in healthcare, but only as a way to help people to achieve their own goals. And for me, in my daily practice, that really helps to put myself in perspective and just in the right place. And I'm just there to help the person sitting next to me.
Geert, can you wrap up your message so that we can go to live music and then to the Q&A section?
Yeah. So we asked the people to do to provide us with actions for each dimension. We asked the people to join together. So I think we can do lots of things in the caring community on the basis of prevention. So we improve self-care, and we build social interactions, and we make communication with people with mental health problems a bit easier. So we have group sessions like how to talk to my neighbor. I will skip this and I will just end here. I think there are still many challenges, like the stigma, and we always say the same thing. But on the other hand, I think that we are working on it by using positive health, and mental health is just one of the ways, one of the dimensions. But I see much more opportunities, and for myself, I'm very happy to work in a community like this, because it really helps to keep my mental health on a high level. I thank you.
Thank you very much, Geert. We have some questions in the Q&A part, but there is room for more questions. Before we go to the question and answer part, we for now go back to the live music of this evening, the Co-operative Harmony performing from Haywood in England, and they're already there. Okay, please go ahead.
Stay on the ground.
All right, thank you very much, Co-operative Harmony. That was Damilola Fati, Ayola Fati, David Kelly, and James Crawshaw. Thank you very much for a great performance. And we'll see James Crawshaw again for the Q&A part, and also he will close this webinar. And one comment on Leuven, because we were welcome to Leuven, and the important thing is that EUCOMS will be, in fact, be present in Leuven in September. We have a meeting of the European Sort Outreach Foundation, 22 September to 22nd September. So, in fact, Leuven is, we're coming, so be prepared. We have some question Q&A, and I'd like to hand over to Dineke.
Yeah, the first question was from Thor. What did you start with? But when did you start with the primary care psychology in Belgium?
I don't know it exactly, but in my gut feeling, it must be about 4 or 5 years ago. And the problem is that before they started, there were some pilot projects. So having this kind of first-line psychologist being present in GP practices or not, things like that. But certainly there has been for this year a new start of the first-line psychologist with a new convention that makes it more structured and goes broader than it was started, so that it also takes a public health perspective as a starting point to search for good places where the needs are the most high, and to struggle a little bit with this problem of inequity. That's one thing, and also that there is the possibility not only to work in a one-to-one situation, but also with groups. So that's the new convention that starts now. But as I said, it's not that clear how it will, how the evolution will be in the next years.
And the interesting thing is that the primary care psychologist started in the Netherlands around in the years 70s of 1970s, some even in the 60s, and they disappeared slowly after change of the system in 2014. And there is hardly, or there is just only a handful of real primary care psychologists. And but they're all almost everyone is going to retire within a few years, so it's different. It's interesting how it goes and how the influence of the system, how much a system can influence.
Yeah, but as far as I know, in the Netherlands, you have also mental health workers working together with the GP in the practice, isn't it?
Yeah, more the nurses.
Yes,
the nurses
yeah.
or the basic psychologist. Yeah. Yeah. I've got also a question from Diederik. Did you discuss with these practitioners how they think to work more closely together? What are the obstacles and in their daily practice about collaborative care? James also, and Lies also said the importance of collaborative care. And what's your experience with that?
Yeah, well, here in Leuven, in Wilson, where I'm working, so I went to see everyone here. I just asked them, are you going to join our caring community? We're going to start with this collaborative way of thinking, because we're probably not working so efficient as we should be. And everyone is involved. So the obstacles were probably that everyone's just doing their job as they thought they were supposed to do, and no one was getting them together. So now we are on a monthly base, we are gathering together around teams, and it goes from somatic care like diabetes, and as well as we have meetings with the primary care psychologist, and we think about organizing group sessions, and so we are all involved now for the same population. So the obstacles were, I think, that we didn't know each other, that payment mechanisms are not in favor of these kind of collaborative work organizations. So now with the chronic care project that I mentioned, we have the opportunity to be able to pay for some time that we get out of our offices to collaborate and work together, so that we can provide the same quality or even better quality wherever persons enter, so that everyone in our neighborhood knows who's best placed if one question comes. So what we are also trying to do is we try to connect with the civilians living here, because we see, I didn't mention it because of the time, but we have a virtual community where we see that people are asking, the threshold for asking for help is much lower for themselves, but also for neighbors. They ask that they see that someone is not opening their curtains, and they go and see them. So I think, yeah, it's just by starting, and we all have the same. Well, I still believe, because I was a bit confused about the lack of empathy and accessibility and relation building by James and in the UK, because for me that's the keystone of primary care. So if this is not there anymore, then you don't have primary care. So it's the reason why we started this job. So this is the reason why we are GP. So I couldn't be able to work in the kind of system, and I see that in the NHS, many of my colleagues are having difficulties working there as well. So yeah, here I think the obstacles were just irrelevant. And we are getting there by working together. We are coping with them, just because we know that we can't deal with the burden of problems that are coming to us in the next years. We should rethink our way we are working now. There's no other way.
Lisa, you're training a lot of GPs. Can you tell us something about it?
I think the reason that the research that I did showed that what works is a communities in practice model. By having shared values with your community and listening to your community and engaging with them, we can actually help shortcut some of this complexity. We talk about some of this silo working. We talk about, that's our language, that's health language. That's not the community's language. And I do think by sharing values and by working together, we can start overcoming those barriers. What it takes is leadership, and people who do this kind of work burn out very quickly without the help and support. So I do actually think by working again and looking at different kinds of leadership that are out of health and are in the community, to me, I've learned would make a real difference. So it's much more about opening up our own borders, as it were, to actually work alongside our community to make the difference. And that to me is collaboration. But it's all about shared values, listening to the community and building on those values together.
Thank you. There's a question about from Tuba about the role of nurses, because you also a nurse of us before, a nurse, Lisa. Can you answer the role of nurses? But the question was sent to Geert. But first, Lisa, what do you think is the role of all we said in the community?
I'll tell you what I found. So what I found was that the people who use the primary care, they actually really liked the practice nurses, because the feedback I got on the work underneath the workforce was the GPs only had 10 minutes, and in fact locally it's been cut down to 5 minutes. So the GPs only have 5 minutes, whereas the nurse would take a holistic, that was the word that was used, a holistic view and ask questions that are wider. So the nurses spent more time with people and they were able to use their opportunities to do health checks, but to actually ask how people are. So there was a much more understanding about compassion. What I did find though was that nurses are not trained. Only 5% of nurses have training in mental health. So they're not trained in mental health, and it's actually, for practice nurses working in primary care, it's actually some of the languages are completely different for them. They don't understand it because they've never been taught. They don't have those competencies.
Okay, Geert, what's the role in Belgium from nurses in primary care?
So in practices, there are not so many practices who have nurses. So it's coming. It's getting there. So in my own practice, we're thinking about, well, with the other practice, so we're thinking about hiring our mutual nurse. So we don't have a community nurse. So I would like to have a nurse because of the things that Lisa said. I agree. But there are practices said that there are community health care centers who have nurses and think they can work together on a more easy way. So we work with home nurses, and the home nurses, they go to the houses, they do home visits. But often we don't know them. We don't have this collaborative way of working together. So we have a lot of work there. I think there is a good job for nurses in our primary care practices, for sure. Mental health and somatic health, and we don't need to divide that, because if someone's there for the diabetic foot, then you can talk to the people and ask, how are you and how are your children? And so that's the role the nurse can play, or the physio can play. I think many physiotherapists play an important role in mental health care. They aren't here, I think, this evening, but so they have a half an hour. They do physical things, but it's a way of connecting that we forget.
From a perspective of positive health.
James has music, and some people have their body. Yeah.
Marc, can you tell us something about the role of patient in collaborative care?
The role of the patients?
Yeah.
Certainly. In fact, they should be the first source for when you are starting collaborative care. You should be invited to work in co-design, to produce new care systems. So I think it's more a kind of methodological point that for all things we do in primary care, we should involve the people to know what their needs are, to know what their goals are, and that should be our guidance more than our theoretical frameworks use to think about health. So that's, I think, the most important part, the way patients can have, they certainly have the high meaning.
And do you work with peer support in mental health?
when you talk about our education, yes, we work with peer support. When you mean peer support in the collaborative care system?
Yep, peers with mental health experiences.
Yes. In my region, that's not really developed yet. So that certainly will be things to think about.
James, how do you think about peer support, experience peer support, mental health problems? James,
yes.
Sorry? James.
Yes.
What do you think about the peer support, the need for peer support?
Definitely. Sorry?
What does it mean for you?
It means a lot. You need somebody there. If I was to ring up my GP, like I said before, and have to wait 2 weeks for an appointment, that's no good. You need somebody there with you while you're going through your struggles. And there's a lot to struggle through. So having somebody there would help a lot. That would be a very, very strong part of helping you relax, knowing that you're getting some help coming to you.
Okay, thank you.
And the peer support models that we tend to have are very much based in secondary care and psychiatric services. But in the UK, you've got to remember that we're all patients. Mm-hmm. So the support that you needs to be within the community and accessible, as well as within the danger is that it sits within secondary care, and actually it needs to come out into the community so that everybody can access it. I think it's really important.
Yeah, it just seems to be there's a lack of communication between patients and doctors a lot. And like I said, I know that GPs are very busy and they've got a lot on, but also that doesn't, that still doesn't mean that the people with mental health care should get shoved to the side, which it constantly feels like it, because there's nobody there for somebody who's got mental health issues, unless you can find somewhere, like I said, like Recovery Republic, but then you have to overcome a stigma as well. But these places, this is where there's a lot of peer support here. You come here and the first thing people do is smile at you, not ask you if you want a cup of tea. How are you? You're all right, but there's no expectation from it. There's just people there. And that means the world, especially when you're waiting for an appointment, even if it's your secondary care appointment. It just means so much to have people there that are on the same level.
Is that also one of the opportunities there is for the long waiting list and the tight labor market and the empathy you said was so important?
Yeah. It's a very important place.
Is there in the UK a special education? We've got in the Netherlands on all different levels education for peer support. Do you also
there's a national organisation which is, I actually based my research on it, which is a slide I didn't show, but there's the National Service User Network, which actually developed standards back in 2013, which are excellent. That if everybody followed those, when you actually look at the impact of what you do and measure whether or not you made a difference, I think is absolutely vital. So the National Service User Network framework, look them up on the internet, they're an amazing organisation, and they do a lot of work. One of the problems we've had in the UK is one of the services that we've seen over a third being cut down is the service user groups. We used to have a large number of service user groups that were independent. They're no longer independent. They're more likely to be commissioned by health now, which takes away that independent voice. And yet they were originally built in the 1970s based on the union movement. And it's thanks to those service user groups that we have things like passports and the way that people go where they want to be, crisis houses, befriending, advocacy, all came up through that movement. So we're seeing those being cut, and we should be supporting and advocating for more patient groups and I think it's really, really important.
Thank you. Before I give you the last words, James, please we go back to René.
Yes, thank you very much, because we are already in the last 5 minutes, and we always give the last word to the person with lived experience. Before that, doing that, I really want to thank all the speakers that we had. Thank the live music from the Co-operative Harmony. Thank Lisa Hale, Marc van Nuland, Geert Pint, and of course Ovidio Unichuk, who you could not see, but maybe you can turn on your screen with video, because we will be nowhere without, if we didn't have a video who makes sure that the technique is running, that we can do these webinars. So thank you very much for that, Ovidio. Already like to announce the next webinar of EUCOMS that will be on the 25th of January on our thematic group of models of care, and then we will go to the situation in France, in northern France, in Lille. Very interesting mental health care, very good connection between community mental health care and hospital mental health care. So already put in your agenda also on a Wednesday evening from 7 to 8:30, that's Central European time. And already mentioned, we will be in Leuven with the European Institute of Outreach Foundation, EUCOMS, in September 20 until 22nd. Having said that, I now give the floor to James Crawshaw. Ask him, in fact, to reflect on the last 1 hour and 30 minutes that we spent together. So please give us your reflection on this. Then after the meeting will be over, we have many questions on the Q&A. We will check carefully if there are questions not answered yet. We have very active speakers who, in part from speaking, already answered many questions also in the Q&A, but we will check if everything has been answered. And of course, you can always reach us via our websites of EUCOMS and EFPC. James, please, can I give you the floor?
Thank you very much, René. I'd just like to say once again, thank you everybody for this opportunity to talk to you all and explain what life can be a little bit like. It has been a very, very long journey since I was in my early teens to get to a point now where I feel like I am back to being a valid member of society. I can volunteer and I can do things, and that happened within a few months of coming here. And it's been getting passed from one GP to another and hearing a lot of jargon that was unable to be understood, not understood, sorry. And after listening to everybody talking today, it's strengthening to know that, GPs do care, because sometimes you walk away from your GP place and you think they're just not listening, not listening. But I just hope that a lot of people out there that are listening really could take on board the fact that although the GPs are very, very struggling, we know that it's tight and it's difficult to get an appointment, try and find a place that is safe, secure, full of other people with similar issues, like this Recovery Republic where I go to. So if you can't fit somebody in, you can't talk to them for 2 weeks, give them a place where they can go to get some help or some empathy, somewhere where they can go and be involved in something instead of sitting in the house thinking, what's wrong with me? What's wrong with me? Why do I feel like this all the time? It's very important to feel valid, especially when your mental health tells you that you're not. So I hope that that can be taken on board. And thank you very much for listening. Thank you.
Thank you, James.
Thank you very much.
That's a wonderful final. That's a wonderful final message.
Bye-bye, everyone.
We close this meeting here. Bye-bye. Have a great evening. I'll see you again.